All right, welcome everyone to this webinar on ethical decision making in these uncertain times. Karen Lehman, MHS President and CEO, will be leading us in a conversation with Jerry Lyle and Bill Scheer. I'd like to take a moment to briefly introduce Karen and our panelists today. Karen began in her role at MHS in 2018, following 25 years of experience working in the fields of healthcare and aging services. She brings extensive leadership experience to the areas of strategic planning, benchmarking, and quality improvement, and implementing operational efficiencies. After a full day in the office or on the road, Karen enjoys spending time connecting with her family, getting outside for a walk or bike ride, and continuing her regular yoga practice. Jerry Lyle has served as President and CEO at Fairmount Homes since 2008. A native of Texas, he is a graduate of Huston College and holds a bachelor's degree and a master's degree of business administration from Eastern Mennonite University. He is a licensed nursing home administrator and has served in the senior services field since 1991. His career included various positions, including social services director, compliance officer, director of supportive living, executive director, and vice president of a home health agency. Jerry and his family are members of Forest Hills Mennonite Church. Welcome, Jerry. Bill Scheer started in the CEO role at Mennonite Services Northwest in September 2019. He brings more than 30 years of experience as a healthcare executive. Most recently, Bill served as the executive of the medicine program, Oregon Region of Providence Health and Services, for 8 years. Working with program medical directors, his responsibilities included the medical subspecialties, private practice primary care alignment, clinical program growth, and outreach coordination for the Portland service area. Bill's very first job while in high school was working as a certified nursing assistant for 3 years in one of the skilled nursing facilities where his parents were the owners. That direct patient care experience taught him the joy of serving others and grounded his commitment to servant leadership and healthcare as his vocation. Welcome, Bill. We will have time for Q&A following the panel discussion. Please use the Q&A button at the bottom of your screen to submit your questions. You are also encouraged to use the chat function. Thank you, Karen, for leading us today. Let's go ahead and dive in.
Thank you, Twyla. I really appreciate that introduction. So we're going to start our conversation with Jerry Lyle. Jerry, I understand that early in the COVID-19 pandemic, your organization made the decision to admit and care for persons that were COVID positive. Can you share how you processed that decision?
Yeah, thanks, Karen, and Twyla for hosting the event. Yeah, back in, I guess, the beginning of March, we did create a COVID task force that met daily to really help us navigate the uncharted waters. I mean, during this time, we had numerous conversations with the local hospitals that we serve about the potential of assisting them with possible admissions, really in case that the hospitals became overcrowded. The task force, boy, we prayed daily for wisdom, for direction. We created policies and procedures and discussed the many questions and concerns that we were having as a team. You know, we listened to our staff, we listened to our residents and our families. Everybody had questions. We had questions ourselves. But the task force also met with our nursing department and really to assess their comfort level of potentially working with COVID positive residents. And remarkable, we received full support from a very dedicated team who volunteered there to work on the COVID unit. And they fully embraced the idea. We made sure that we had available several weeks of worth of patient protective equipment in case we ended up with many numerous positive cases. And I would say my goal from the very beginning was to provide opportunity for open and honest communication. And once we had the buy-in from the team, we really started to then do research on what to create a negative pressure isolation wing to help us reduce the potential spread of the virus. again, none of us really had the experience in this. So we reached out to numerous folks. We learned then that the University of Colorado School of Engineering created this type of isolation wing in a hospital out in California. So we reached out to them, and after numerous FaceTime meetings with them, meetings with our medical director, our respiratory therapist, we're very fortunate to have a respiratory therapist on staff, and reading as much as we could from Center for Disease Control, Pennsylvania Department of Health, we created the unit. We shared the idea also with a couple of our donors, and they were really willing to help cover the cost associated with the necessary equipment needed. And some of that equipment that we purchased were fans, filters, protective barriers, and even created anterooms. And at that point, we retrained our staff. Obviously, our staff is trained on infection control, but we retrained at that point. From the very beginning, we also wanted to make sure that we were focusing in on our core values. All of our conversations that we had really focused back on our mission statement, our core values, but we also lived with the motto, faith over fear. And that's pretty much how we came up to the point of creating this isolation wing, and it's been very successful.
Would you share, Jerry, what some of the specific ethical issues were that you had to consider in making this decision?
Yeah, actually quite a few of them, but I truly believe that Fairmount exists. We exist to care for not only our residents on campus, but we also serve the broader community who are very vulnerable and compromised. And we also want to be a faithful witness as Christians in our Anabaptist believer, in our Anabaptist faith. Lots of questions. We wrestled with lots of different questions. You know, at this point, we didn't have a template. Everything was so unknown. So we didn't really have anything that we could use to help us create this and address the issues that we had. So we asked lots of questions, concerns. We wrestled with the question of how do we fulfill our mission of serving the community, but also upholding our core value of compassion? Well, keeping our own residents and team members safe, and that's definitely a priority. Other questions were, will we be able to minimize the risk? What happens if our team members don't agree to care for the COVID positive residents? But also, what happens if we create this isolation wing and we can't contain the virus and other residents in our building and team members become sick, or even worse, what happens if we experience death? So we really had to talk through the different scenarios for all of us to feel comfortable with bringing in positive residents. This was also at the time when we were hearing that some of our retirement communities in the Lancaster area had started acquiring positive cases and really trying to keep the virus out of their community. And I even remember I had a few of my peers question our decision and really wondering, why would you bring the virus into your campus when many of us are trying to keep it off our campus? The task force addressed these questions internally, but we kept coming back to the fact that we want to serve the broader community. And I also remember one conversation we had in our task force meeting. A member really compared our decision to the parable of the Good Samaritan and asked us if we were the priest or the Levite who walked by the beaten man, or did we want to be the Samaritan who stopped and cared for the man? Obviously, we all agreed. Definitely. We wanted to be that good Samaritan neighbor who helped those individuals in need.
So I'm just wondering, did you at any time regret the decision or wonder why you chose this path?
Well, yeah. Lots of angry telephone calls, emails from families that had no idea what we were doing, why we were doing it. So yeah, I guess I'd have to be honest and say that I did question the decision at times. It's not easy for an organization like Fairmount, who some might consider us very conservative, too conservative. And we're really not known for taking risks, but we did keep true to our mission. I still remember one family member He called me and threatened to report us to the Department of Health and even to Fox News. But I had the Department of Health telephone number handy, so I gave that to him. If I'd had the Fox News number, I probably would have given that to him as well. But he was quite angry with us. Didn't understand why this was happening, and he was afraid that it was going to compromise his mom. But also, after all these angry emails and phone calls, I do remember our very first COVID patient that we admitted from the hospital. He had spent 4 weeks in the hospital and 4 weeks in our COVID wing without seeing his wife. That's after 8 weeks of not seeing his spouse. The day he was discharged back home, the team purchased balloons. We brought in a cake. We celebrated, but we also then lined the sidewalk as he was being wheeled out to meet his wife for the first time after 8 weeks. I just remember that. Still gives me chills to think about it, but the smiles on their faces were priceless. They embraced each other. We all clapped and cheered for them, and so that's always a special moment that I will remember. We also then obviously got full support from our board of directors as well. I vetted the idea with them early on in our planning, and they were very supportive of the idea. And even at our board meeting we had this past Monday, the board wanted to reflect back on that decision, and unanimously they still agreed that we made the right decision. And actually one of our board members stated, do unto others as you would have them do unto you. And it was really encouraging to continue to hear and feel their support that they provided for us.
Well, that may be addressing my last question to you about how are things working out today,
well,
given this major decision that you made.
Yeah, to date, the only resident COVID cases on campus have come from admissions from the hospital or actually from other healthcare facilities. We've had a couple personal care facilities in the Lancaster market that had quite a few positive cases and they couldn't handle them. So they reached out to us and we took several of their residents. But none of these cases have spread to other residents. In fact, on Tuesday, we had the Department of Health come in and they did their infection control survey. 2 surveyors came in, reviewed our policies and procedures, and they even wanted to tour our COVID wing. So we took them back there, obviously all dressed in their PPE. They were very impressed. They hadn't seen anything like it before, and really talked with the staff and just got a good feel for what was happening back there. So looking back on it, yeah, we would do it again. We would make that decision again. Obviously, there are some things that we would do differently, but we would do it again. We thought that we over-communicated our plan at first, but looking back on it, I don't think we were clear in the reason why we were doing it. Why did we create this isolation wing? And so that was some of the things that as we reflect back on, we would probably change. But yeah, it's been very successful so far.
Thank you, Jerry. So I'm going to move to Bill. So after the CARES Act was passed and we learned about the Payroll Protection Program, the grant or loan, whichever one how you want to refer to it, what were your immediate thoughts about this program and how it would help your affiliate communities?
Sure. So my immediate thoughts were that we should explore the program through the lens of the challenges COVID-19 was placing on our organizations and or was likely to place on our organizations. So the approach we took was our Vice President of Finance did an individual, I would say, conservative, wise steward approach to assessing the PPP opportunity for each of the 5 organizations we manage. We then took that analysis to the finance committee and or the governing board of each of those 5 entities for their consideration and decision on whether to pursue a PPP loan or not. So we took a very deliberate, very intentional assessing the opportunity approach and then entered into transparent dialogue with the boards of the 5 organizations we manage. I think you're on mute, Karen.
That's probably the most spoken "you're on mute" words that we are using these days. So were you surprised when one of the affiliates made the decision not to apply for the grant? And do you mind sharing their reason for not applying?
Sure. So I was a little surprised. However, I appreciated their thoughts and perspective, which was a very selfless perspective. This particular organization at the time and currently to date has had no cases, staff or resident, of COVID-19. They have a very strong operating reserve. And so in looking at the opportunity, their board looked at those two factors of their financial strength, their lack of really any challenge with COVID-19. And so as a part of their mission of serving the larger community, very selflessly, they determined that there were probably other organizations in their community and the surrounding area that could better utilize those funds and may be in more desperate need. So while they could have met the parameters, I'm certain they could have justified their case through their mission and the lens of that mission to serve the greater community. They made a very selfless decision not to pursue those finite funds so that others had them available to them.
And then would you also share the reason why your other communities did apply for the grant?
So 3 of our 5 communities, organizations did move forward with the PPP loan. I'll use the largest of those as an example. It's a large CCRC. And while it had not had any positive cases of COVID-19, they had multiple instances where a resident and or staff member had COVID-19-like symptoms and were then tested. And during that testing, as early on in the pandemic for skilled nursing, other healthcare facilities, you were put on restricted admission for both a staff person and a resident who may present symptoms. So there were multiple instances where the skilled nursing facility, the assisted living facility were both for weeks at a time on admission hold, which significantly impacted their census, decreased their revenues, coupled with the additional expenses of PPE, of dedicating screening staff at entries, other operational changes that they needed to make in terms of COVID-19. So for them, the impact was very real and was very tangible and was very ethically defendable. So they moved forward with their loan.
So have you, since this, we're a couple of months past now, have you had any misgivings or concerns about the decisions that were made?
I've not had any misgivings, concerns in regard to our approach because I believe our approach was very intentional, was very transparent in dialogue and decision-making with each of the governing bodies, and with each through the lens of our mission and our core values and our greater service to the community. So I believe it was the right approach. It was intentional. It was ethically informed by our mission and core values. Only concern is, as sometimes happens with government programs, after the fact, the government expectations and rules around the documentation and audits and other things required of those PPP loans seem to be evolving and increasing. And so those are my only concerns kind of after the fact, but I believe we took the right ethical approach to the decision-making with each of the 5 organizations.
Well, thank you, Bill. Just going right along with your remarks about your decision-making around the PPP loans, I'd like to also just share a bit about MHS's decision-making around the CARES Act as well, and the, as you call it, PPP, Payroll Protection Program grant. So we had early on several other Mennonite Church USA agencies and others that we were aware of were applying for the loan. And so when we looked at that early guidance, which was of course very limited, this was the first round, we felt that we qualified, that MHS as an association would qualify for the grant. We had losses related to canceling Mennonite Health Assembly in March, and so it really seemed clear to us that we could apply for this grant. So after we stepped through the process and made the application, and after we received the grant and then received additional guidance regarding the qualifications, and of course we know that there was so much more scrutiny after that first round because so many large corporate organizations got the grant, and so they started tightening the guidance. And so we then took a look at that and really felt like we did not qualify for the grant. We kind of stepped through a process in terms of our thinking through, early on we felt we qualified based on what we knew, and then based on then the guidance that came out, there was some clear direction regarding assets, organizational assets that can be used, and also direct expenses due to COVID that we felt were really on the edge. And so as we thought through that process, we thought about, if we had to share our reason for taking the grant, would we have to defend it? So that was one thing. Would it feel like we're making a defense in taking it? Another issue is how would we feel if the decision was made public and then there would be public scrutiny? And we also know, around our members, and what would our members think about MHS getting the grant? And so based on those kind of stepping through those processes or those decision-making points, and then also just the leadership of MHS, we all just kind of instinctively also had the sense that we should give it back. We felt that based on what we now knew, we should return the funds. And other than having our banker really question our decision, there really wasn't any other follow-up. And then the later guidance that has come has been even more lenient. Now it's gotten more lenient, and in retrospect, of course we could qualify for it, but we still felt confident and felt what our decision was appropriate. So that's just another kind of angle into that PPP loan and the decision-making process that wasn't really through a flow chart, but was really kind of looking at, that defense of and public scrutiny, and then also our instincts on it. So we're going to move past PPP, the CARES Act, and some of the COVID, and move into some more conversation around ethical decision-making. And I'm going to turn to Bill here with this next question. So throughout the pandemic and now, there are other things that organizations are grappling with. So besides some of the operational issues around obviously accepting government funding and decisions around admissions and who's served, there are always things that come up which may on the surface seem straightforward, but when looking a bit deeper at the implications, we find ourselves considering, what is the right thing to do and what is most consistent with our values. Over the years of experience that you've had, along with working in different faith-based systems, would you be willing to share some of the kind of the tried and true principles that you've learned to use as a guide in navigating ethical decisions?
Sure. So prior to my current position, as Twyla mentioned in the introduction, for the last 20 years, I was in Catholic healthcare. 7 years with Catholic Health Initiatives and 13 years with Providence Health and Services, Oregon. Both of those Catholic health systems had a resource that they made available to leadership when difficult ethical decisions needed to be made. Frequently, those decisions were around continuing or discontinuing a service, but they could have been around initiating a new affiliation. It could have been around a significant capital decision, et cetera. But the tool and resource made available to us was a very structured, comprehensive, mission, vision, and values-driven, facilitated by a mission leader or a chaplain in the organization decision-making process. It involved all of the key stakeholders in the decision-making and evaluated all of the alternatives through the lens of the mission and core values. That tool and process was called ethical discernment. Frequently, the decision was still owned by an individual or a couple of individuals. However, my experience in the 6 or so times I went through an ethical discernment with those Catholic health organizations was that it was an extremely helpful tool in informing and giving guidance, mission and values, ethical-driven guidance to the leader or leaders who needed to make the right decision. An overview of the Catholic Health Initiative's ethical discernment process and tool is available in the public domain. And so I'm happy to share that with participants on this call that kind of gives an outline of how it works, how it's facilitated, how it ties to the mission and values. And so if it's something that may be helpful to those that are part of our webinar today, glad to share it with you.
Thank you, Bill. Appreciate that. Jerry, in your organization, there are some differences in the services and amenities that you provide due to the relationship of your sponsoring church. So how have you and your board worked through some of those differences that for some organizations might not even be on their radar for discernment? And you're free to open this into any other kind of discernment that you've had, whether it's with the church relationship or not.
Yeah, I can kind of share a little bit. We're very unique. We're a very conservative mindset organization here in Northeast Lancaster County. A couple of years ago, we created an advisory board to really help us connect better with the Plain community, meaning the Amish and other conservative denominations, churches. The advisory board, they attend regular board meetings with us. They provide input. We ask for their input. They provide suggestions on how we can better serve their church members. And out of those discussions, the advisory board discussed creating a discount for residents that come from the Amish and Plain community. So the question that we really grappled with was, we were looking to provide a discount for one particular need that was in our market, one particular group, and not another group, meaning those that have insurance, private pay, whatnot. So I remember we really discussed it at length. We talked about it. We met with other individuals in the Plain community besides the advisory board. But after much discussion, we decided to create an elder care charity fund. And in support of its conservative Anabaptist church constituency, we do maintain a certain number of charity care beds. And these are really just solely dedicated to providing care for members of the conservative Anabaptist churches who really cannot afford regular admission. They don't meet our admission criteria financially. And we are admitting them at a reduced rate. The fund has increased a number of our healthcare admissions from the conservative churches in our area. I think just by creating the advisory board, it really has helped us build positive relationships within this group. And we've seen a significant increase in also financial donations to Fairmount. It's been a great, great partnership. We're also seeing more and more of the Amish members come into our short-term rehab program. And so I would say the addition of the advisory board has been a tremendous resource for Fairmount. It has really helped us meet a specific need in this area. I know it doesn't work for everyone, but for us, we don't allow television in our healthcare and personal care. So with that, it does align very well with the Amish and conservative churches. in our mindset. And so it's been tremendous asset for the organization. But we really did struggle with the idea of, we are providing a particular group a discount and not the other. But the way that we have looked at that is, well, they don't have the insurance, so it doesn't, it's less time on our part having to bill insurance. And so providing them a discount has been really beneficial for the organization.
Thank you, Jerry. So before we turn this back over to Twyla for questions, is there anything else that either one of you wants to share? We're good. All right, Twyla, we're going to turn this back to you.
Sounds good. I appreciate the participation coming in through the chat and some Q&A. So please continue to submit your questions using that Q&A button. You should find it by hovering at the bottom of your screen. I believe our first question comes from a participant. And I think this relates back to what we were talking about earlier with Jerry. So we'll start there, but others can feel free to answer as well. This person asks, did accepting COVID patients from the outside allow you to better navigate the financial challenges that other CCRCs have experienced as a result of closing down outside admissions?
Yeah, so when we looked at creating our isolation wing, COVID wing, at that point, we really had to start discharging. We cleared out a 13-bed unit. We moved some individuals to other areas of campus. We sent people home that were ready to be discharged. So we did take a financial hit at first. But since then, we've admitted 22 individuals into our COVID wing. And there is a financial benefit, and we found that out after the fact. Medicare does allow for a COVID payer classification that we can bill, but that's not the reason why we decided to create the space. Financially, obviously, it has helped us. We have always and continued since the beginning of the COVID virus, we've continued to admit from the hospital and from outside. I know there are some individual or organizations that chose not to do that, but we did. We took the risk. We moved them into our COVID unit. If they were coming in for therapy, we tested them twice to make sure that they had 2 negative tests. And once they did, then we were able to move them off the unit into the rest of our rehab section. Or once they became eligible and ready to be discharged back home, we did make sure that they had 2 negatives before we discharged. So again, financially, it has helped us, but that was not the reason why we created the unit.
Thanks, Jerry. While we have you here, we have a few more questions coming in for you. Perhaps you can respond to this next question. Do you think the COVID unit you developed at your facility is a model that others can use in the future?
It is. I do think that we are actually looking at creating this for the long term. So as we speak, we are meeting with some HVAC contractors to look at how this could be for the long haul. What we did is we created it. It's temporary. It's a temporary solution. But what we are looking at, and now that we have the full support of our board to look at it going forward as well, we are seriously considering making this more of a permanent. Again, we don't know how long this COVID virus is going to be around us, but it also, this unit could be very instrumental in flu outbreaks as well. So again, we are in the process. We're still working with the University of Colorado in a model that we can use for going forward.
Thanks, Jerry. Last question here before we open it up to Bill and Karen as well. Did you revise HR policies related to requiring employees to work in the COVID unit? Would they have been terminated had they refused?
Yeah, so we created lots of policies and procedures as related to HR and infection control, but we did not have any of our individuals that were back on that unit. They volunteered to work there. We did not make them, we did not require it. And even to this day, we've had no problem staffing it. I think we had one individual that she had a 1-year-old child that she chose not to work back there. And so we were able to move her elsewhere in the building. But no, we did not make anyone work in the COVID unit. Thankfully, I'm not sure what we'd have done if we did not have the buy-in. But as I mentioned earlier, we wanted to make sure that we had the buy-in from the staff from the very beginning. That was important to me. It was important to our task force committee, and it has worked. We did we provided a bonus about halfway through the end of April, beginning of May. We gave a financial bonus to every team member that works at Fairmount, no matter if you work back in that unit or not. We wanted to make sure that everybody felt important. We understand by bringing in COVID positives into the organization that no matter if you're in laundry, housekeeping, dining, everybody's taking a risk. And so we wanted to financially reward them for it. So we gave out a financial bonus to all 320 of our team members. Obviously that helped, but we still had individuals back there that were volunteering to work.
Thank you, Jerry. I'd like to direct this next question to Bill. Bill, as a leader, we sometimes have an instinct about our decisions. When do you follow your instinct versus when is it best to use a decision-making process to make the decision?
So I don't think I ever rest on instinct alone. And so I'm a very data-driven individual. I try to gather all of the facts relevant to the decision. I try to engage the appropriate stakeholders to help inform that decision in complement to intuition. So even though there may be kind of a leaning or even a leading, you may sense, of the spirit in making a certain decision, I still tried to factor in a framework of our mission and our values. Is it consistent with that? What does the data show us around informing it? So I try to take as comprehensive as possible. Sometimes decisions have to be made quickly, but even for quick decisions, there's opportunities to try and gather all the information you can and make the most informed decision you can through the ethical framework of your mission and values.
Thanks, Bill. Maybe while we're on that question, can you speak to how you integrate your spiritual sensibility or faith into decision making?
Sure. So oftentimes we use the terminology navigating difficult decisions. In fact, Karen's question to me used that language. And an analogy that was shared with me many years ago by another leader that I carry with me and remind myself of time to time, it really comes from the old hymn, Jesus Savior, Pilot Me, where there's a line that says, chart and compass come from thee. Jesus Savior, pilot me. The analogy that was shared with me many years ago that helps me bring spirituality into my decision-making was that for us, our chart is our mission and vision. Our values are the points of our compass. And just like the captain of a ship who's navigating stormy seas has to trust in an invisible force to direct them through the lens of their compass, their values, so too, we need to trust that as we look to our chart, our mission, as we look to our compass, our core values, the Spirit of God will direct us in making the right decisions.
Thank you so much, Bill. We have a couple more minutes here, so I'm going to keep moving through the questions before we close here. Someone asked if that reference to the Catholic-based mission assessment tool that Bill referenced would be shared. And the answer is yes, we will provide that via email as an attachment in the follow-up to this webinar. So thank you for asking about that. Another question for Jerry here. Jerry referenced a task force that was formed to help process COVID-related issues. Jerry, can you talk a bit more about who was a part of that or what roles were a part of that task force, and maybe provide an example of how that task force handled a specific decision and the ensuing communication and implementation of that decision?
Okay. Yeah, so the task force, when we created it back in the beginning of March, we really wanted to get all disciplines on the committee. So we do have Director of Human Resources, Vice President of Health, Vice President of Operations, Medical Director, Director of Nursing, Director of Personal Care, HR, Marketing, and also our Infection Control nurse. The task of that committee, we meet every day. We've been meeting every day, except for the weekends, but every day at 9:30 for about half hour to an hour. And a lot of the questions and decisions that come our way are coming from maybe it's residential living. Maybe it's coming from a family member in healthcare. Maybe it's coming from HR. And when I referenced earlier policies that we created, we really sat and talked through policies and procedures. Really wanted to be clear that everybody had a voice on that task force. So I would go around the room, and I still go around the room and ask every individual in the room to give their opinion on a decision. And that has been very helpful. It really has been helpful to get the buy-in from the entire team. And if we don't all agree, we don't all agree, and sometimes I have to make decisions. But it's been also helpful to have our nurse practitioner. She works very closely with our medical director. So any of the medical questions, and she's a WellSpan Health employee, the local hospital. And so it's helpful to have her on that committee as well, because she can tell us some of the information that she's hearing from the hospital standpoint. And we can bounce ideas, problems that we envision happening here, and maybe the hospital has already worked through that. So it's been very beneficial to have her on the committee. And some of those decisions that we make, just this morning, we were making decisions on Pennsylvania, or Lancaster County is now going to go green as of tomorrow, meaning that more and more businesses are going to be opening up. And what does that mean for our residential living residents? We've not allowed any visitors on campus, but we took those questions back to the committee this morning. And so out of that, we have a list of things that we're going to start allowing starting on Saturday. So it's those type of topics and conversations that we have at that task force meeting.
Thank you, Jerry. Thank you so much, Karen, for leading us in this conversation. And I want to give a special thanks to Bill and Jerry for joining us. It's been an incredible privilege to hear from you. And thank you for having the courage to speak to your experience in a difficult time as well.
Sure. Happy to be included.
Thank you, Twyla.
Yep. So I have Karen's email address up here. If there are additional follow-up questions, you can feel free to reach her there. We will also be sending out a brief follow-up email with a survey, and would appreciate any feedback you have. I'd also like to give a quick plug for our next webinar coming up on July 30th. We've invited Apapan Nussbaum, the Diversity and Inclusion Coordinator with Everence, to talk with us about a social psychological approach to diversity and inclusion. So we really hope you'll join us for that. You can sign up in our upcoming newsletter or on our website, mhsonline.org. So thank you so much and have a great day.